Thank you very much, Mr. Chairman. Thank you to you and Senator Murray for taking this issue so seriously, for putting us on a path to a bipartisan product coming out of this committee, and also a path to bring this to the floor this year. I think this is one of our opportunities in 2016 to be able to move something substantive, something bipartisan, something that makes a difference on the floor of the Senate. And I thank all of you for being here today. I think we've covered this question of capacity well, and I thank Senator Collins for her specific questions related to the IMD exclusion. But just for a minute, let's think about how this would relate to our lives. If we were to bring our child to the emergency room around dinner time, and we sat there with our child all evening, we sat with our child all overnight, and we didn't get appropriate care for our child until noon the next day, we would call for people's heads at that institution. We would be outraged. That isn't the outlier when it comes to people being admitted to the ER with mental health diagnoses. That's the average. And yet we sort of have accepted it as commonplace. But there's a reason why that's happening. We've closed down 4,000 mental health inpatient beds since 2007 in this country. In the last 2 years alone, we went from 91 million Americans living in an area that was designated as a mental health shortage jurisdiction for outpatient services to 97 million Americans. So we're going the wrong way on capacity as need is increasing. So it's no mystery as to why we're hearing these stories. But as Senator Murray pointed out, another failing of our system is the lack of coordination. The fact that we have so many people trying to do good things, but they're not talking to each other. And for really complex patients, it's often not clear who's in charge. For a child, is it the school? Is it the mental health clinic? Is it their primary care physician? And so, Mr. Rahim, your story was so captivating, and you're so courageous to continue to tell it. I wanted to ask you about this question of coordination. I wanted to ask you the question about the barriers that patients face in trying to find a quarterback for their care, the worry that's involved in just trying to figure out which provider is the best place to start, where they eventually go to get the care they need. How can we do a better job of coordinating all of the good things that are happening in this system so that it's easier for patients to navigate?
Right. So I can take a step back and share what happened with me about 17 years ago now. My parents were able to bring me directly to a hospital in Queens. I was and you talk about the waiting area being chaotic. I thought that I had hallucinations in the waiting area. I thought that I saw Jesus and prophets, but I was able to get hospitalized that night, right? And I was able to get medication that night. And I was able to get in the ward that night, and I spent 2 weeks there. So I think that early care, as Dr. Hepburn is talking about, is so critical, but I was able to get that in that moment. To speak to the larger issue and larger problem, I think that having that care, the immediacy of care is so critical, and I know it was critical for me.
Dr. Eaton, I wanted to explore very quickly an issue that you raised, which is this realization that if we don't spend money on mental health, we're going to spend money somewhere else. And that the fact is that a diabetes diagnosis alone doesn't put you in the top 5% of spenders in the Medicare and Medicaid system. And in fact, a depression diagnosis alone doesn't put you in the top 5% of spenders. It's the combination of the two. And as you point out, if you have depression, if you have a mental health diagnosis, you are frankly much more likely to acquire another major and expensive physical health disorder. Can you talk a little bit about the connection between a mental health diagnosis and then a very expensive, very burdensome physical health diagnosis, and why a little bit of spending on the mental health side prevents you from spending a lot of money on the physical health side?
Well, I wish I knew more, actually, but that finding, depressive disorder, predicting to diabetes or stroke or heart attack, that's been replicated 10 times. It's unquestionable, and therefore the logic is very strong that on the one hand, treating the mental health disorder will almost certainly lower the risk for the physical disorder later on. And but also preventing the mental, moving upstream, even farther than first episode psychosis. So if we can identify people at risk for psychosis,